Hello and welcome to today's discussion. I'm Sarah Luttrell. I'm the Communications and Events Manager at the Center for International Development at Harvard University. I want to just kind of launch into a couple of housekeeping items before we start the presentation. So as you know, there will be a Q&A session after Amanda's presentation, which will be between 15 and 20 minutes. And then the Q&A session will be about half an hour after that. You can submit questions during that session directly into the chat. So feel free, we're trying to keep this as a more informal conversation to add any comments or clarifying questions as the presentation is going as well. You can use the raise your hand function to ask questions directly of our speaker. We're also recording today's session and the video of this event will be available on CID's YouTube channel. I'll add links to our YouTube channel and also to sign up for our newsletter and social media channels in the chat. And finally, next week, I hope you've all heard or gotten emails from CID about our annual Global Empowerment meetings happening next week, or as we like to call it, GEM 20. GEM 20 is now for the first time being live streamed. So it's a week-long conference. We'll have events every day, sometimes multiple events per day. And we have a fantastic lineup of speakers, including 4 Nobel laureates, which we're really excited to be inviting virtually to campus. So don't miss this opportunity to engage with leading policymakers and development experts. You'll be able to ask your questions directly online to our panelists over our YouTube channel. Through the live stream. So I'll also include links to that in the chat as well. But without further ado, I would like to introduce today's speaker, Amanda Beatty. Amanda is an MPID alum from 2001, which I hear is the first class of MPIDs. She's also a senior researcher at Mathematica, which is based in Cambridge, Mass. Most of her research is related to education and community-driven development, mainly in Indonesia. Which is also the subject of today's talk. And before joining Mathematica, Amanda worked at the World Bank, Millennium Challenge Corporation, and RAND. So Amanda, thank you so much for being with us here today, and over to you.
Great, thank you. Thanks, hi everyone. I guess just to ask if, since this is a small kind of intimate group, can I ask how many people are MPADs? I don't know, you can raise your hand or, I don't know, make a reaction in Zoom or say hey in the chat or something like that. All right. Rohit said he's an MPID. Okay, there are a couple of you. Are there any Indonesians in the audience or people with great affection for Indonesia, like me? Okay. And I guess my next question is, should I assume everyone watching knows what stunting is? Yes, there's a nod. Kristen gave me a nod. So we're going to talk about stunting. Stunting is length or height for age, and a child's considered stunted if the child falls below 2 standard deviations on kind of an international distribution. It's just a short answer. Okay, with that, I guess I'll get going then. Is that all right, Sarah? Okay, give me a nod. All right, so where's my, oh, share screen, okay. There we go. All right, how's that look, everyone? Yeah, okay, so since we only have a little bit of time today, I'm mainly just going to launch into kind of the intervention, our research design, and then some of the findings. I'm happy to talk more in depth about the findings or anything else you're interested in. We could also talk about recommendations if people are interested in that in the Q&A. Okay, so background about the project. This project was funded by the Millennium Challenge Corporation. MCC's name for the project is the Community-Based Health and Nutrition to Reduce Stunting Project, really a mouthful, which was $120 million, implemented in 11 provinces. So there are 34 provinces in Indonesia, and implemented from 2013 to 2018, so over the course of 5 years. The provinces selected for the project were intentional. They were based on stunting rates, previous experience with one component of the project called PMPM Generasi, which I'll talk about in a minute, and also just interest, willingness to participate. I think the focus on stunting really stemmed from a recognition by the government that stunting was a huge challenge in Indonesia. I mean, long before 2013, even in 2013, Indonesia's stunting rate was around 36% nationally, and which is quite high for Asia, high for Indonesia's GDP per capita. And so this had become a national priority. And you know, when the government was discussing potential options for MCC funding, this came to kind of the top of the list. All right, so this is a slide about the intervention. I think it's important to keep in mind there were 3 kind of categories or bundles of lots of different activities. This is a large project, as the $120 million was spread out across these different, as MCC calls them, activities. So starting on the far left over here, the community projects activity or PMPM Generasi was an existing government project. That's the community-driven development aspect of this initiative. So what is Generasi, or what was Generasi? It's kind of similar to a traditional CDD project in the sense that grants are given to communities, and then communities can decide how to spend those funds. It's different from your traditional CDD project in the sense that this project didn't focus on small infrastructure, but rather focused on particular activities to support the achievement of particular health and nutrition indicators set by the project. So the project set a series of 10 indicators, and communities were supposed to use funds to improve outcomes related to those indicators. So just to make this like a little more concrete, Generasi funds were spent on things like trying to get women to prenatal appointments, or for snacks and transportation, for group counseling sessions for pregnant women and women, mothers of young children. So that's Generasi. I think the other reason that Generasi was quite important, and the other reason MCC decided to support Generasi, was there was an existing evidence base. So there had been a rigorous impact evaluation done by Ben Olken and others, which demonstrated impacts on things like vaccinations, on children being more likely to be weighed monthly, and also on stunting in a few project areas. Okay, so the supply side activity in the minute, so Generasi was supposed to be the demand side activity, so actually helping people access services, where the supply side, the theory was that this would be a series of activities that would improve quality of existing services. And this mainly included training. There were a couple of different aspects to this, but a lot of it was training health providers in infant and young child feeding, in growth monitoring, and also in CLTS, or community-led total sanitation, which is a model that tries to use community outreach and community building to reduce open defecation. Along with those training components, their MCC also supported distribution of anthropometric kits. So this was length taking and weighing equipment that went to local health clinics that was especially like portable, so that health providers could use them more easily, carry them to communities where there were community meetings focused on length taking and weighing. And then the last piece of this was iron folic acid distribution. And then finally, the smallest component of this project was this national communications campaign, which was focused on that was implemented all over the country through social media and television, around proper hygiene, healthy eating, proper sanitation, and also general healthy behaviors, and there was a big focus on just educating the communities about what stunting is and why it was important to prevent it. So this entire bundle of activities was hypothesized to or hoped to improve knowledge, behaviors at the household level, and then that was supposed to ultimately reduce stunting, underweight, wasting, and low birth weight. And I think it's important to remember, as like, you know, this is just a preview to the results, is that many of these activities were supposed to happen kind of simultaneously in a way that would, you know, synergistically affect children in the first 1,000 days of life, right? So from in utero up to age 2. Okay. So our evaluation basically was trying to look at this package. I mean, the communications campaign kind of happened everywhere, but basically in the treatment areas, we looked at the package of interventions on things like behavior, receipt of health services, and other child health outcomes that I'll go into further when we talk about the results. All right, so this is a randomized control trial. The random assignment happened at the subdistrict level or the Kalimantan level across 3 provinces. So remember that the project was implemented in 11 and the RCT was in these 3 provinces. The main reason we selected these 3 was they had no prior experience with generasi. And so this was an opportunity to offer generasi plus the applied side activities in the treatment group, whereas the control group wouldn't have access to generasi until the end of the evaluation. Okay, our data collection basically happened over, you know, there's about 4 years between baseline and end line. The kind of project implementation happened over the course of 5 years, although I'd say the core of it was during these particular three years. And then when we say maximum exposure 3 years, is we're thinking about, okay, what cohort of children would have the highest potential of receiving the benefits of the project. So I'll talk about that in a minute. All right, so now going into the results, this is where we start to talk about impacts here. So this is stunting. Results are similar for underweight, wasting, and low birth weight. And what you're looking at here is changes in stunting for control and treatment groups. The treatment is green, control is blue, and this is for 24 to 35-month-olds. So we basically measured children, followed children in different cohorts, and so this was from 0 to 35 months, and we selected the oldest cohort because they were hypothesized to have had the most potential exposure to the project. So this is the cohort that, you know, had the highest potential to see an impact on stunting. And you probably can notice here that they didn't, although I think there are a couple things that are important to that are interesting about this figure. One is stunting went down. So we see it also go down in the control group. So I think this is a nice case for an argument for the importance of having a control group, because we see it improve. In both cases, this is largely driven by an improvement in severe stunting. So there's an improvement for the kids who are most severely affected. And yet we don't see a difference across treatment and control. Okay. So going on to the other set of outcomes, I have 3 other outcome slides, and then I'll talk about explanations for why we don't see an impact. So this is on health access and community participation. I think that the general thing across all the outcomes here is that I would say we do see an impact on some of the lower level outcomes. I would call all of them modest. So I don't have the levels here. I can go into that further into the Q&A. But so while we see, you know, this is just to describe the slide, the impact summary column is obviously just arrows. That's for more of a lay audience than this audience. And then the adjusted impact column is, we say adjusted here because we basically are controlling for a host of background characteristics and also clustering at the Kalimantan or subdistrict level. So we see some effects on children being weighed and having their length taken more frequently, and also women attending these counseling sessions, group counseling sessions, not on prenatal checkups, deliveries, or postnatal checkups. This gets into the behaviors. So we see some effects on IFA consumption, that's self-reported consumption, exclusive breastfeeding, and complementary feeding, and yet not on immunization, diarrhea, or diagnosis. So we basically, because we weighed and measured a large sample of children, we know whether they were stunted or wasted based on our measurements. So we also compare whether they were diagnosed as being stunted or underweight. And then this is the sanitation side. So a key component of the CLTS model is an activity called triggering, which is basically kind of the initiation of this community meeting to commit to reducing open defecation in the community. And this, 16% differential, percentage point rather, differential that we see here is it's an output of the project. The project supported triggering. So we're seeing that kind of happen in higher frequency in treatment areas, but not much else going on the sanitation side. Okay, so next I have a few slides on why we think we don't see impacts. The first is a synchronicity that I mentioned earlier when I was describing the project. The hope was that a large share of the providers would be trained in 2014 and 2015, and you can see that here that there's actually, a very small portion of them, and a large portion were trained kind of in 2017, which is when Generasi was starting to wind down. So the hope was that these highly skilled providers would be ready for when Generasi, increased demand for services, and that synchronicity didn't happen. We also, I think there are a couple issues with the CLTS model. One here, what I'm showing here is the share of providers that were trained on CLTS. I'd focus on the sanitarians because they're the main audience for the training. And you can see that quite a lot were trained in control areas. And that the difference, our question is this difference of 24 percentage points enough to affect higher level outcomes? Meaning, like, would we expect to see impacts with just a 24 percentage point difference in terms of providers trained on the CLTS. Another point on CLTS is this triggering that I mentioned earlier. We don't see a big difference in terms of triggering across treatment and control areas. This slide is another explanation for potential lack of impacts, is just the amount of contact that providers had with the community. So a big part of the theory of change was that Generasi was supposed to induce much more interaction between providers and community members. And so while we're seeing, some more people going to this Posyandu is like a monthly meeting where children receive weighing, length taking, vaccinations, some general kind of health counseling. So we see kind of small improvements on the Posyandu side and attending these classes, but you can also see here that the share of women participating in these classes or group counseling sessions is still quite low. So our hypothesis here is maybe there just wasn't enough interaction between providers and the community. And then this is my last slide. Lastly, there was, this is obviously in Indonesian, this is from a national report showing changes in stunting throughout the country. So the takeaway here is that there was a national reduction of 7 percentage points in stunting between 2013 and 2018 around the country. And so while of course it's possible for an intervention to have an even bigger impact on stunting, the question is, like, would we expect, an intervention like this combination of supply and demand side activities to have an impact above and beyond these national trends of reduction in stunting? So that's it. I'll stop there. I'm happy to talk through questions if anyone has them. Thank you.
Great, thank you so much, Amanda.
Yeah.
And just a reminder, everyone, if you have a question, please use the raise your hand function, or you can add a question right into the chat, and I'm happy to read those for you. I guess that's a lot of information probably to digest in a short amount of time. Also, if you have any clarifying questions about kind of the content or the strategies used, those are also very welcome. I guess I have a question, Amanda, about, so it seems like implementation was something that seem to be lacking in this project, kind of a more coordinated sense. Would you agree with that? And are there any recommendations of how that could be helped in future projects? And maybe was this a specific example or case from Indonesia that had specific, localized problems as well?
So I think so. The way that MCC and many donors, this is not unique to MCC, bundles projects. It's usually not just one thing. It's like many things at once, and then there's a story around kind of how this is going to have transform the area or the community for whatever outcome you're looking at. I think that there's a big risk in doing that, because I just think that if you can, going back to the slide on implementation, so you have a government ministry basically with support from the World Bank, but basically implementing generosity, right? One ministry, which is like this Ministry of Villages, and then you have the health ministry implementing all of the infant and young child feeding and the community-led total sanitation components. You have a private firm basically doing the communications. That didn't have to be so synchronized, but still, that would be the hope. And the IFA distribution is happening, through the health ministry, but at a very local level. So this is a long answer to your question, but I mean, I just think I think it's super hard to get all of these ministries coordinated at the same time, and to expect, if anything, I wouldn't criticize the implementation. I would just criticize the ambition, the theory that we're going to get all of these things to kind of happen at the same time, when there's just, especially training. This was a cascade training, so which I'm sure like happens in many, many countries, but you have like, people at the national level, training a certain number of people who then go and train others, and et cetera. And that just takes a long time. And then there are always breaks in the chain of the cascade. And so, I think I would caution against kind of, I think there are a lot of issues about the theory of change that made this a very ambitious project. And the synchronicity was definitely one of them.
Okay, thank you. Yeah, that definitely makes sense. It does seem like a lot to kind of take on at once. So we do have a question in the chat from Tankuri Ja. So I'll just read that out. They thank you for your presentation, and they were curious to get any specific insights you have on severe stunting numbers improving. And I'm not sure if that's just in Indonesia specifically or more broadly, if you have any experience.
Yeah, so this is like, the most exciting finding, right? from the study. I think it's also nice to have corroboration, right? Because we have these national numbers going down, and we see here, I'll pull up this, and our numbers also go down, right? This is across the 3 provinces for this particular age group, but we see a decline in stunting kind of all throughout the country, almost every province. And so no, I don't have a good explanation, right? I wish I did. I think that was what our number 1 recommendation is, to try and figure this out. I think that was underway by a number of because obviously the government has been monitoring this, right? These are the, these are the government results, and you can see the severe stunting is is basically the far left set of bars, and you can see the 18% to 11.5% is the big reduction that we're looking at from 2013 to 2018 in this figure, and so you know, there were several government entities working on this. I think a couple things that I'll say. One is just this became a huge national priority. So the government really, you know, put a lot of effort into reducing stunting and kind of threw the kitchen sink at the problem. There's also just, you know, a pretty good growth rate happening. So Indonesia's getting richer, people are getting better off over this 5-year period. So, you know, I don't have a good answer. I guess the other thing I would say is I think that I suspect that a lot of the effort that was going to go into figuring this out and to further reducing it now has been, you know, shifted because of COVID-19, right? I think that, you know, while Indonesia is doing very aggressive, you know, cash transfers and other things to support communities, I think a big concern is that we're going to see stunting go back up.
Great, thank you. We have another question in the chat from Khalil Lausi. I'm sorry if I mispronounced your name. They were asking, other than not having been exposed to similar programs before, what are some other factors that were considered at baseline to ensure homogeneity among the populations in the 3 regions?
Oh, you mean like kind of how we tried to balance? Yeah, so I mean, going back to, you mean just in terms of the randomization? So we certainly, like, you can see here that there, you know, we ended up with 95 treatment, 95 control, and we tried to balance on characteristics. I think, I don't know if we might have had stunting data at the subdistrict level that we balanced on, but I mean, basically any kind of relevant health outcome data that we could have used, population size. Yeah, we did the randomization a long time. I can't remember everything we balanced on, but I mean, basically, you know, we certainly tried to ensure similarity, and they, like, you know, we did a number of balance tests, and at baseline they were similar.
Great. We also have another question. Shahbaz, would you like to ask the question yourself?
Oh yeah, it's a small group. We could.
Yeah.
Hi.
Oh, I think you're still muted. Let's see.
That looks better.
No,
I can't hear him though.
I can't hear you. Maybe it's with the headphones.
Can you hear me now?
Yes, that's perfect.
Thank you. Thank you for your presentation. So, of course, it's informative and very relevant about the context of developing countries, including the country of intervention. So my question is, nutrition intake of mother has a great role in stunting. So what interventions were in this project for mothers, in nutrition intake, and was there any analysis of that aspect in your research? Thank you.
Sure. So you're exactly right. I think a big issue is mother's nutritional impact. That a big issue that has a huge impact on low birth weight, right, is mother's nutritional impacts. So intake. So the things that potentially. So short answer to your question is, we certainly did some very crude kind of measurement in terms of what people ate, but I wouldn't call any of that really conclusive. Like, this wasn't really a deep dive into kind of dietary intake. But the interventions, in this project that were supposed to affect this were a lot of the communication pieces. So all the providers were trained extensively on maternal nutrition, and were basically, through the training, expected to impart this knowledge on the communities. The second piece of this was that in these counseling sessions, which were run by local midwives and volunteers who supported this kind of monthly weighing and length taking sessions, those providers were trained, and then in these sessions where women came for information, they also did like cooking demonstrations and tried to, you know, encourage the use of healthy eating. And they also provided kind of supplements at that particular kind of counseling session, group counseling session. So there was some kind of, I would say, very minimal supplementation for pregnant women, along with a lot of the counseling pieces. But there wasn't any kind of, in terms of best practice, like intervention from a like food perspective. Like they didn't receive, I guess the other thing I should say is that also women who were eligible received like a monthly, a basket of healthy foods. So they received kind of like in-kind support. But it wasn't something that you see in maybe other countries that are, you know, like high calorie nut-based supplements or things like that. That wasn't part of the intervention.
Right, thank you.
Great, are there any other questions? And Sanjeev, would you like to ask a question yourself? I think we are a small group. It might be nice if you're able to ask.
Hi, am I audible?
Great, there you are. Yep.
Great. Thank you for the presentation, Amanda. My name is Sanjeev, and we have been involved with extremely low income indigenous remote groups here in Meghalaya, India. And Meghalaya has one of the highest infant mortality rates and maternal mortality rates. And I wanted to ask you from a stunting and working with mothers standpoint, what is the role gender has played in this project? And also when you talk about complex subjects like this, and we have so much of English used, both in terms of the cognitive aspect and also the communication aspect, were there specific challenges you faced to communicate when you interact with low-income indigenous remote groups? Thank you.
Okay. So, okay, the first aspect was gender. I think, Sanjeev, can I just clarify that question? Do you mean kind of how, you know, how men in these households were involved in supporting kind of maternal and child health?
Yes, that's, yeah, one of the aspects.
Yeah. So I don't think that this was a big barrier as it is in some other countries. I think that there, you know, of the things that we looked at, we looked at kind of how, I don't have a slide on this, but basically kind of decision-making power within the household and who decides on kind of what groceries are bought, or whether women have control of the funds to buy food for their household. All of that was pretty, you know, it was a minority of women who really didn't have access to their household finances, or who didn't make decisions about their household like food intake. We have, you know, a big part of the project, and actually, so as I mentioned, Generasi had 10 indicators that communities were supposed to try to improve outcomes on. And one of these indicators, which was added, you know, in this next phase of Generasi that was supported by MCC, was, you know, male household involvement in these nutritional counseling sessions. And they went very infrequently. Let's see if I can find the slide to show that. Here we go. This was basically on whether the spouse attended. There was no difference across treatment and control, but you can see that, you know, for pregnant women, about, you know, 15% of husbands reported going, and for the class for caregivers, it was a little bit lower. That's also, I mean, not a lot of women went either. So I think I have the women's slide between there. Yeah. but so there was an effort on the part of the project to kind of get men more involved. I don't know if that was the right approach, right? I wonder, these classes are not held at times that are convenient for men, for many community members, also for women. I think that was part of the reason that many didn't attend. So I guess I question I think there are a lot of issues with some of these sessions, which were a big part of the project. So I don't think, I guess my summary point here is, I don't think that, women's access to good nutrition in terms of like being a big gender issue. I see it as much more of an economic issue. And then your second question is, everything in this project happened in Indonesian. So I used to live in Indonesia, and I speak some Indonesian, and so all of our survey work was in all of the communications and pretty much everything happened in Indonesian. There, in these areas, there are some other local languages, especially in Kalimantan, but the community members, like who were in charge of doing outreach, were also able to speak those languages. Did I answer that question? Did I understand your question on the English piece? I've Anglicized everything here merely for presentation purposes.
Great, thank you, Amanda. Are there any other questions that maybe anyone has? It's a small group. It's a great opportunity to ask any kind of particular questions, whether it's about the presentation, about Amanda's work in international development, or her career trajectory, anything that you are interested in. Yeah, Khalil, if you'd like to ask your own question.
Hi, thank you so much for the presentation. I'm sorry, I came in a few minutes late as well. I just wanted to ask if your slides live somewhere that we can access, because it was a lot, so I didn't get a chance to really digest it.
Oh, well, Sarah, I don't know. Do you want to answer that?
Yeah, sure. So we will be sharing this presentation on YouTube, so you can go back to any of that. And then Amanda, if you share the slides with me, I can share with anyone who is on the call today.
Okay.
And also link on YouTube as well. Yeah,
I'll just find out if that's okay with MCC. But our report, I think you might have put the link to the report in the chat, Sarah, has everything and more that was covered today.
Great, and I'll link again.
And that's public, yeah.
We have a couple more minutes. We might have time for about one more question if anyone wants to ask anything. Nothing burning. If not, I guess I'll ask my own question again.
Okay.
So Amanda, also, I guess kind of more, and apologies if you've kind of answered this, with the project, what kind of incentives were there for people to get training or to become involved with the project, other than kind of just the educational piece and maybe some kind of food?
So on the supply side piece, there was all of the providers trained were either government or local employees or volunteers, community volunteers. So there was definitely high demand for training, high interest in training. I mean, there was a problem. There were problems with training execution, but for the most part, people really wanted to be trained. I think there's just issues with midwives being away from their practice for too long, things like that. But generally, there was a lot of interest on the community side. Yeah, I think this was a big problem. Generosity, the theory of change of generosity is basically okay, there are community volunteers who kind of generate community interest and support and educate people about the importance of maternal and child health and work with the community to try and improve outcomes related to the 10 generosity indicators. I guess I can show those. So I think that certainly it's that there's a lot of peer pressure. I think that's the main incentive, but there's not, and I said the in-kind support, which is like the food support, which a lot of families received through the project. These are the indicators. But other than that, there isn't, you know, you either have to kind of need the service or feel peer pressured, or, you know, have gotten a lot of social media messages about it, or, you know, want this food support. But other than that, I'd say that's kind of the incentive in a nutshell, really. Yeah.
And so was there a lot of social media kind of attention? Are there specific platforms that are used in Indonesia to kind of?
Yeah, I mean, the information campaign definitely like was all over. There were a lot of TV commercials. There were a lot of Instagram posts and things like that. You know, some of these communities, like, that's not really accessible to some of these communities, and so there were also just, you know, community members who were sending the messages. But I think, and CLTS is like, you know, a huge effort. It's like a lot of community work to get people to stop open defecation. And it involves, I don't know, for those of you who are familiar with CLTS, it's a model that uses a lot of community shaming. But you know, I don't, I wonder how effective. I think in this case, I think you know, I'm skeptical that it had a big impact and that it was very effective and really resonated with this community, right? So I think maybe that's another lesson, is like, you know, while Generasi had obviously been, you know, well tested in terms of being a project that seemed very worthy and made a lot of sense to fund the project. I wonder if they could have been served by doing a little more piloting on the CLTS front.
Great, thank you. We have another question. Daniel, would you like to ask your question?
Yes, thank you. Good presentation. What do you think could be changed the outcomes?
Do you mean how could they have had a bigger impact on stunting?
Exactly.
Like what outcome? Okay. So, well, I mean, I guess one thing I should say and remind the audience of is that, you know, two things could have happened here, right? One is that the project actually had an impact on stunting, and there was something going on in control areas that had an equal impact, but the project, you know, I think we can't say that the project was totally ineffective. So that's one option. Another option is that, you know, there were activities, projects, forces completely outside of what was happening in both treatment and control areas that helped reduce stunting, right? That have nothing to do with the project. I lean more towards that, I think. But in terms of like how, I mean, stunting clearly went down. We're still trying to figure out why. We don't have a good answer for that. But I think the general question of how to reduce stunting is pretty unanswered in the research. I think there are lots of theories, but they're, you know, that have links to obviously sanitation, have links to a lot of the components of this project. So sanitation, exclusive breastfeeding, proper nutrition, etc. But none of those is kind of like a slam dunk. You know, I do a lot of my work is in education, and if you asked me, you know, how could I design a project to make sure that like every child can read by grade 3, I think there's a very good evidence base for that. If the question is, you know, how do I get my stunting rate down by 5 percentage points, 10 percentage points, I don't think the research is as clear. So Daniel, sorry, I didn't really answer your question. I think I have a lot of theories about kind of what we could have done, what the project could have done to improve either implementation or maybe think about a different model for addressing some of the challenges. But I don't know that this was the right set of interventions to address stunting.
Thank you very much.
Great, and I guess we're over time, but maybe Khalil, can we'll ask the one last question, and feel free to ask yourself.
Sorry, last one, I promise. I just wanted to know, did you guys do intra-province evaluation and then compare that to the overall outcome to see what those look like? And then in your report somewhere, are there, sorry, do you have errors reported in there somewhere that we could see as well?
The standard errors?
Yeah.
Yes. So we did look at outcomes kind of by province, and those are in the report. And so especially there's a large appendix, I think it's appendix 10, where you can look at all of the outcomes and by, you know, province, by age group, by gender, et cetera, and the higher level outcomes. So these stunting, wasting, underweight, low birth weight. And it's like a standard regression output table. So anything you would want to see is in there. I didn't use those for this type of presentation because most of the people I have presented to, and also the report was written for an audience that you know, might not have an econometric background.
Got it. Thank you.
Sure.
Great, so thank you all for joining, and Amanda, thank you for this wonderful presentation and for your time answering all of our questions. And we look forward to one day hosting you in person at HKS. And
yeah, sure. I'm probably closer to HKS than most of the people here on the call right now.
I know, so weird times we are definitely living in. But thank you all for your time, and we hope to see you next week at some of our GEM conference, which is happening every day live on our YouTube channel. You can also register for our public event on Wednesday with the 3 Nobel laureates in economic sciences from 2019. So again, feel free to look in the info in the chat and join us next week. And we look forward to seeing you at the next speaker series on October 2nd. Thank you all so much.